Good afternoon. I was hearing a couple of our speakers checking in. Again, this is Keith Coker in the Medic Coordinating Center. Thanks for joining us. Why don't we get started? We're still having some participants joining. We're in the 50s at the moment, but we anticipate several more. So welcome to Virtual Grand Rounds. I'm Keith Coker. I'm the director of the Michigan Emergency Department Improvement Collaborative, or MEDIC. We've been hosting a number of town halls on the COVID-19 response for emergency departments within our network. We thought this would be a good time to draw on lessons being learned, particularly from sites and health systems in Southeast Michigan. Bear with this because we pulled this together in less than a week, but we have a great set of panelists, and we're going to talk through some of the things that we are learning and discovering in centers in our state that are being particularly hard hit by the pandemic. A few housekeeping items. Because we're anticipating a large number of people on the call, we're going to keep everybody on mute, except for the panelists, to cut back on any background noise. We are planning a question and answer period, though, so we encourage you to use the chat function. We're going to be moderating that and bring up some of those questions and comments at the end of the hour. So let's set this up. This is probably a pretty familiar dashboard to many of you. This is from Johns Hopkins. We pulled this data this morning, and as you can see, our state is particularly hard hit nationally and really even internationally in comparison. And if you focus at county level, again, across our country, Wayne County in particular is an epicenter. If you look across your state by county, again, Southeast Michigan, you can see the counties listed here: Wayne, Oakland, Macomb, Genesee, Washtenaw. And we think there's quite a lot of learning that's been going on at these centers that we can disseminate across our state. One final slide. This is from Columbia University, another forecast. We're pretty used to seeing them these days. But this is at the county level, a worst case scenario, and certainly we hope with the mitigation efforts with social distancing, we won't see this come to pass. But this is sort of a worst case scenario of when we exceed hospital capacity at the county level over the next several weeks. So all that is to say that we all need to be prepared. I'm sure many of you in your emergency departments have encountered cases of COVID already, but we can draw on some of the experiences from these health systems and have pulled together a number of panelists from Henry Ford, the Detroit Medical Center, and Michigan Medicine. Want to make sure there's a disclaimer here. Some of the therapies for COVID-19 may come up on the call, things like hydroxychloroquine, and just want to make sure that people understand that the FDA has not approved any particular product for specifically treating COVID-19. The format that we're going to take is a round robin. We're going to open it up to each site for about 15 minutes for the panelists to discuss and then move on to the next site. We'll save about 15 minutes or so at the end, again, for a question and answer period. And again, we'll use that chat function and we'll be monitoring that. So bring those comments and questions in and we'll bring those up later. The kinds of topics that we're going to be hitting. First, we've asked each of the panelists to, at least at a high level, debrief on their ED's pandemic experience, and then to address some of the items that we have listed here. One, sort of a playbook for respiratory support. I think there's been a lot of discussion, particularly in social media, around some of these strategies for escalation in respiratory support, and we want to pick the brains of our panelists throughout this. I think another area that we read about a lot is risk stratification. Are there biomarkers? What are ways that people are navigating this decision in the emergency department about those that need to be in the hospital versus those that could go home? And of course, another high priority area around workforce safety, conservation of equipment. Just a quick word about MEDIC, because there may be a number of you that are not familiar with our project. This is a support improvement network. We have 23 hospitals and are growing. The coordinating center is at Michigan Medicine, and we're funded by Blue Cross Blue Shield of Michigan. Okay, so we're going to start with the Henry Ford panel. I'm going to ask that each of the speakers introduce themselves, and again, we'll have about 15 minutes for them to discuss their experiences. So I'm going to pass the mic over to the Henry Ford panel. You should be unmuted and available to speak.
Yeah, thanks, Keith. I'm going to start it off. I'm Namita Jayaprakash. I'm one of the EM intensivists at Henry Ford Hospital. Hopefully there aren't any technical issues and you can hear me.
No, you were coming through.
Great. So 6-7 weeks ago, I think we were all bracing ourselves, listening to the reports out of China and Italy, and we were very much in this we need to get prepared mode. But very quickly and rapidly, we found ourselves needing to adapt. And we at Henry Ford Health System have really felt like we've taken over a Herculean effort to respond to this pandemic. In the emergency department in early March, at the start of March, it was very clear that in the preparation phases, we were going to have to tackle not just of course, the walk-in worried well, we were going to have the EMS traffic, and then how do we respond to the critically ill? This pandemic, the new novel coronavirus was clearly most importantly affecting the respiratory system, and so we had to anticipate a surge in the critically ill. At Henry Ford Hospital, boarding of the critically ill patient was not something new to us. But nonetheless, it's been a very interesting learning experience. So just to give you some brief statistics on where we stand at Henry Ford Health System, so far we've had 2,208 COVID positive admissions. Of that, 43% of them have come through Henry Ford Hospital, the Detroit campus. At Henry Ford Hospital, Detroit campus, we've discharged 71% of those with a 9.8% mortality so far. 317 patients have been admitted to the ICU, and 65% of these have been ventilated. At what we hope is the peak, or a few days ago, just about within the last week, we had 182 patients admitted to ICU beds at Henry Ford Hospital. So this has been quite a phenomenon for us to experience. And like I said, our early responses involved a lot of effort from our leadership team, but it also each of us stepping up into our leader. So our operations team was focused on setting up the tent early on, understanding what our walk-in needs were going to be, how are we going to separate COVID versus non-suspected patients. Our EMS colleagues work in partnership with EMS companies to find the process patients arriving in ambulance phase, synchronizing those systems with way up the emergency department flow. We partnered with facilities at a health system level. So understanding where our negative pressure rooms were was important. Not only was this a virus that was affecting and impacting critically ill presentations, it was a virus that you had to deal with healthcare transmission risks, aerosol generation. So understanding what our current institutional abilities were in terms of negative pressure rooms and things like that really impacted the development of the flow. So we were partnered with facilities to
So I think we've lost Namita, and we can circle back to her. Is there somebody from?
Yeah, I can take over. So I'm Jackie Fallon-Carlson. Oh, she's back.
Back online. Sorry, can you hear me now?
You're cutting out a little bit. Why don't we go with Jackie for now, and then we can circle back to Namita.
Okay, so I'm Jackie Fallon-Carlson. I'm one of the IM critical care trained staff at Henry Ford, and I was going to touch on some of the things that we did to improve ventilation and oxygenation strategies, knowing that there was a very real possibility based on the data that came out of Italy and China and some of our colleagues on the West Coast that ventilator use would be limited. So we realized that without the use of alternative oxygenation strategies, we could quickly find ourselves short on ventilators. So before we saw a major surge in patients, we created a guideline that recommended optimizing safe alternative oxygen therapies prior to intubation. We used the information from the SARS and MERS outbreaks in the past to kind of determine which of the aerosolizing oxygenation tactics were most risky, and then stratified our patient placement according to that. So our recommendations were to maximize the use of Salter devices for high flow oxygen up to 15 liters, then heated high flow via the OptiFlow in our hospital up to 30 liters per minute and 100% FiO2. For patients with a component of bronchospasm, we obtained the filtered nebulizer masks that reduce the generation of aerosolized droplets during treatment administration, and meter dose inhalers in patients who were not in severe distress and can hold the inhaler. We also advocated for BiPAP with the use of HME or HEPA filters in patients who may have had a reversible process coexisting with possible COVID infection, such as flash pulmonary edema or COPD, which are really common conditions in downtown Detroit. All patients receiving high flow nasal cannula at more than 15 liters or BiPAP support were cohorted to areas of the department with negative pressure capabilities that Dr. Jayaprakash was going to talk a little bit more about. And then all providers who were entering those areas were mandated to wear full PPE because of the assumption that there were aerosol generating procedures, and so you are at risk. Patients who could self-prone were asked to do so. So anybody who was on Salter or high flow who had the capability to turn themselves over, we asked them to do it. And then patients who needed to be prone, Henry Ford actually had a proning team who would come and actually assist with proning some of the intubated patients. I don't have the exact numbers on how many patients we proned, but we did prone probably daily in the emergency department at the height of things. Patients, we also, in our initial recommendations, we recommended exploring the underlying etiology of hypoxia if COVID wasn't the primary driver, while supporting patients with non-invasive strategies. So patients who came in with things like narcotic overdose or alcohol intoxication, we advocated for more liberal use of Narcan drips or frequent reassessments by physicians and nursing staff when the conditions and ratios allowed, therefore avoiding intubation of that patient population and saving some of the ventilators for the patients who might need them for COVID or other respiratory failures. In general, we asked that people consider that ventilators could become a limited resource before moving to intubation, and if they felt it was safe, to use high flow or BiPAP to start there. Lastly, we recommended early goals of care conversations with all patients and families. We encouraged people to discuss patient wishes for end-of-life care during their initial encounter when appropriate, but most importantly, when patients' oxygen requirements were escalating and they anticipated ventilation in the future. Later on, we had palliative care in the ED assisting with some of the more complex conversations, which really helped patients and families understand what was going on. They got a lot more one-to-one time with the palliative physician and some of the ER physicians who had obvious competing clinical demands. And they were able to assist in goals of care conversations. I think Dr. Ramesh is going to talk a little bit more about the treatment algorithm and the risk stratification using labs, unless Namita's back on.
So I believe Namita is back. This is Keith again. So Namita, if you're available, you can certainly continue where you were.
Yeah, sorry about that. I don't know what happened. So I think I was getting into our facilities flows and negative pressure rooms. And so we looked at our emergency department as a whole and tried to understand which rooms could be converted into more negative airflow spaces. That also led us into being able to understand our critical care capabilities and what we could safely board in terms of aerosol generating procedures as well as critical care capabilities. And we ended up converting part of our category 1 high acuity area into a COVID ED ICU, which in all intents and purposes for being an aerosol generating procedure area then allowed us to be able to limit the turnover of PPE by just identifying a group of providers who would be caring for that area. And so it led us to doing a lot more closed loop communications, identifying runners and handoffs, and really working on the communication bit, and building on that ICU capability or critical care illness capability in the ED and linking it in with the surge capacity at the hospital level was also important. And so from the EM critical care division, we made sure that we stayed within the discussions of the critical care surge capacity planning, etc. So I'll hand it over to Dr. Ramesh to talk more about our risk stratification and medication approaches.
Hi, good morning, guys. Hopefully you can hear me.
Yes, we can hear you.
Okay, cool. So we worked with the emergency room, Dr. Krupp and other folks, including Namita, trying to come up with a reasonable way to try to minimize patients from going home from the ER and then readmitting. Because early on, it seems like patients were being sent home because of the significant surge we had in Southeast Michigan, where because of bed situations, some milder patients were actually sent home, but 2-3 days later, they got admitted back, intubated. So what did we do to solve that problem? So clearly, they had a fantastic triage system already set up. So my job was to add maybe a couple of things. See, the important thing we realized in this disease process is there is the time to onset of symptoms is the key. And so somewhere like the ballpark of about the second week, early second week, that is when the inflammatory response kicks in, and that's when people get into trouble. So we had to address that early enough. So how do we address that? This one. So we did a few things. So in the first triage questionnaire we did, we asked, could we ask all patients, not did you have dyspnea, but we are asking dyspnea on exertion. So that is one simple question we asked. Then we included an ambulatory pulse ox, making sure that the pulse, not just resting pulse ox, ambulatory pulse ox that is dropping below, say, 92, and that is another concern for them. And third, it's comorbid illness, such as duration of illness, and hypertension, diabetes, morbid obesity, particularly morbid obesity was a big comorbid illness. And so based on these things, we are able to triage the patients towards the next step, meaning they will get a chest x-ray and or EKG. And based on the chest x-ray, if we have bilateral infiltrates, for example, and they then go to the next step of getting the labs and the COVID test done. And the labs include just simple labs at this point. We're looking at CBC with differential, looking for absolute lymphocytopenia below 1,000, for example. And CRP, we just look lowball the figure and say the CRP is about 3. And then, so we didn't wait for other labs, like such as ferritin, D-dimer, LDH, or any of those things. So based on this combination of clinical features, laboratory X-ray findings, and laboratory, it fits the story of COVID. So those people likely gets admitted, particularly if they have exertional dyspnea or exertional hypoxia, definitely. So there was a tendency to admit these people a little bit more. So an organized way to admit them, made the process much more easy and consistent for the main campus triage system. In addition, we also provided our own management guidelines to say that while the patients are waiting to be boarded, because it takes some time, if it is greater than 8 hours, we probably should do something about them by initiating whatever management strategy we have, whether it's an antiviral strategy or any sort of immunomodulatory strategy. We try to start that early in the year. So this system has worked pretty well. We are looking at now to see how many people have actually gotten readmitted. I don't have the actual data at this point of time, but it seems like it's definitely far and fewer from what we see so far. So that's where I'll stop.
Great. Well, certainly appreciate the Henry Ford team's thoughts. And again, we're going to circle back to likely a lot of the points that were raised by them as they were confronting the pandemic. I want to switch to the next team. So from the Detroit Medical Center, again, if you could introduce yourself before you speak. And again, we'll have about 10 to 15 minutes here to hear from DMC.
All right, so I'm going to start. So I'm Ann Messman. I'm the Vice Chair of Education for Wayne State, and I work at Receiving and at Sinai Grace. During the pandemic, I've been probably 2/3 of my shifts at Sinai Grace. So I can speak to both institutions, but I think that Sinai Grace had was more inundated with cases, so I'm going to primarily talk about the care that was provided there. And then Dr. Rosenthal is going to speak next. He's the Associate Director for EMS and works only at Sinai Grace, and he can fill in some gaps. So compared, there's obviously a lot of overlap with what happened at Henry Ford. I would say a huge difference is that Sinai Grace doesn't have the same resources that Henry Ford does. Particularly, we don't have an ICU fellowship, and we don't have palliative care that's easily accessible. So those services were stretched much more thin at Sinai Grace than it sounds like at Henry Ford. We sort of hit our peak, I would say, about 9 days ago in terms of the emergency department being stretched to its absolute maximum. I've never seen it as packed as it was then. By policy, generally, we did not use BiPAP on anybody, even if they were, there for asthma or COPD. I'm just reporting this as information. I'm not saying it was good or bad, but that was sort of what we did. We wore full PPE to evaluate every single patient that we saw. We pretty much considered that everyone was COVID positive. We had similar sort of policies with proning. It was, if the patient was able to self-prone, we encouraged them to do that. We did not have any formal, proning teams that would come around. That was eventually arranged in the intensive care unit, but nothing that was formally instituted in the emergency department. I agree, obviously, with the sentiment of Henry Ford that having very early discussions with family about end-of-life goals was extremely important. A problem that we had at Sinai Grace is that there are 14 nursing homes in our catchment area that come into the emergency department. A lot of the nursing home patients have legal guardians as opposed to family members. And so sometimes those legal guardians, oftentimes they're lawyers that keep business hours. And so it was not always possible for us to get in touch with legal guardians that could give us guidance on the patient's end-of-life goals. Almost across the board, everyone was listed as full code when they came into the emergency department. So that posed a significant barrier for us when we were trying to have those conversations. And also everyone's having the same issue of trying to establish a relationship with a legal guardian or a family member over the phone that you've not met, that can't see the patient. It's very challenging to get code status updated. I would say from a clinical standpoint, one of the things that struck me greatly was how hypercoagulable these patients were. We started measuring D-dimers in the patients routinely about a week and a half ago, and I've never seen D-dimers that were you couldn't even analyze it. It was so high. It was greater than 35. You didn't really know what the actual number was. And so in the last few days, we've instituted fairly aggressive measures, providing full dose prophylaxis with enoxaparin for greater than 3, and then just DVT prevention for dimers less than 3. So that has been helpful. I've seen more saddle emboli in the past weeks than I have probably in my entire career. And the other thing that I wanted to point out is we did end up having to admit a lot of patients simply because they required just a couple liters of oxygen and they had no prior oxygen requirements at home. So they obviously didn't have any tanks. And so they were on the floor able to discharge a couple of patients that just needed somewhere between 2 to 4 liters nasal cannula. They had been stable for a couple of days. In some cases, they were able to get the patient's oxygen tanks to go home with. And that's definitely something that I think should be looked into to see if there's a way to do that directly from the emergency department to spare some of these admissions, because my guess is that when second wave comes, when people start leaving their house and it's more of the younger, healthy people that get COVID and maybe they just need a couple of liters of oxygen, that it would be wonderful to be able to send them home with a portable pulse ox and a oxygen tank, and they can sort of, self-quarantine and stay at home rather than coming into the hospital. And I'll pass it off to Dr. Rosenthal.
Hi, my name is Mark Rosenthal. Am I unmuted properly?
You are coming through.
Okay, great. My name is Mark Rosenthal. I'm also an emergency physician. I only work at Sunny Grace Hospital. I'm the medical director for emergency management, as well as for EMS, associate fellowship director for EMS fellowship. And in addition, with a little bit different background, I'm also a supervisory medical officer for the National Disaster Medical Service. However, I'm not speaking about HHS. I will speak more toward, I think, our operational characteristics in this response and play some of the unique challenges or solutions we had. Our department, compared to a fair number of departments around the country, even before we started seeing a significant number of COVID patients, we figured due to our location, the risk for Detroit due to the significant amount of comorbidities and high density living conditions, really started off the bat with using effective PPE. Even with this, we still had some who turned out to be positive, but we immediately at the beginning started with all patients. You had to wear a face shield or goggles, a N95 mask initially, as well as gloves. If it was a possible COVID patient, we added gowns. And we tried to do it initially to protect our staff, and we're reasonably good about that. Unfortunately, the way our department's set up, we could not do some of the things that Henry Ford reported. It would have been nice to. Our department, while we could technically cohort patients into our four isolation rooms, that's 4 patients only, we tried to maintain patients in our closed rooms. Many of our rooms are just closed off with curtains. We do have a reasonable number of rooms in our department that actually have doors. However, the ventilation system for our department, as well as the Sunny Grace Hospital, is not, say, isolable. The way our department was designed, we have 2 air handling systems, and they both hop and skip around the department. So if you're trying to protect one side of the department as being for our COVID area, if you actually are aerosolizing the virus, it can end up being 100 yards away in a different part of the department if we transfer that far, which made things a little bit more difficult in our department. And it's the same thing in our hospital. Our whole towers cannot be isolated. We do have 2 separate towers, but the floors within them cannot be isolated. We do have isolation rooms, and they were being used, which made management of the patients to prevent aerosolization a little bit more difficult because of the way our air handling system. Also, relatively upfront, when we went from only a few possible PUIs to significant number, literally over a couple of days, we started operationalizing with using, at most of our facility, outside tents to do triage, and it's been reported around the country, At Silent Grace, we actually had an area in the department which is for psychiatry. They were essentially closing down. We used that space to see the possible PUIs who had relatively stable bowel signs to determine whether discharge or admission to the main ED for further evaluation, management, and probable admission. So one of the ways we were flexing, we also flexed our staff in order to accommodate what we were seeing, for better or for worse, including taking into account more senior physicians or those comorbidities would put them at higher risk and giving them their choices of where to be. We were able to sort of maintain, for the most part, our PPE and maintaining either N95 or reusable respirators, which we also have, which I'll explain in a second, with our staff, and then gowns, especially as you further moved on, gowns, hair bonnets, face shields, in order to provide protection to our employees, and also trying to make sure our staff, in terms of physicians, but also hospital employees, the nurses and techs, doing the same thing, which is actually a challenge. We have a grant with NIOSH CDC, which was looking at half-mass elastomeric respirators to be used for actually this type of situation. The grant was funded about a year and a half ago, and we managed to complete our first part of the study, which is basically fit testing within 1 week, a significant number of people, and issuing out these masks, which technically were not supposed to be used until we went to the second part of the project, which is about a year from now. However, NIOSH was very nice to allow us to use it and then use our extra supply to actually get more of our staff using a reusable device and teaching them how to clean it. The brand doesn't make a difference. It's the fact that using a reusable limited our utilization of some PPE, which was nice. One of the bigger things, and part of my job with the DMC, was also start keeping up to date on all the information coming through. It almost is a full-time job to keep track both of social media sites, which people provide their clinical experience, which obviously is anecdotal, versus actually research or publications, whether it be from China, Europe, or the United States, on management of these patients, and seeing how the data was and recommendations were switching very, very quickly, and trying to determine the underlying science as to what was the best practice that we should perform. Some of this reported by Henry Ford. And that was sort of an interesting problem. The virus, just is a very nasty organism, and it's still, I think, not fully clear as what's the best way to manage these patients. Just like Henry Ford, we were proning patients who were awake as well as intubated patients, and trying to manage our flow. It did tax our resources in the department, as we didn't have enough. We had plenty of beds, but not necessarily enough staff between those who were in quarantine, and therefore was a challenge for the department for about a week or so, but it's significantly improved this time as other hospitals. I think that's all I want to talk about now, more in the operational characteristics.
No, that's great. And I think it's a good stopping point, because I want to make sure that we get through the other panelists from Michigan Medicine, and then we'll again circle back for at the end with a few minutes for comments and questions. All right, so I'm going to pass things over to the Michigan Medicine team. If you can introduce yourself, and then we'll listen in. Thanks.
Can you hear me?
Yes, you're coming through.
Great. So I'm Ben Basson. I'm emergency medicine at Michigan, and I run our emergency critical care center, or our EDICU, and to do a lot of kind of administrative work as well as clinical work in that space, which we'll be able to leverage pretty heavily for this patient population. And then Dave, you want to introduce yourself?
My name is David Hackinson. I'm one of the dual boarded emergency medicine critical care faculty, also working in EC3.
So we thought maybe we just get a brief overview. I think as opposed to Ford and DMC, our initial experience was a bit different. As you know, Ann Arbor is not nearly as densely populated as Detroit is. And so our kind of local cases were much less and much more delayed than I think all the Detroit hospitals saw. And so we were fortuitous in that regard, in that we were able to have a little bit of time to prepare as Henry Ford and DMC and Beaumont were intaking large volumes of patients. We were starting to gear up mostly for transfers from those health systems. And I think we've hopefully been able to help out a little bit and take a fair number of transfers into our health system from those hospitals when we could. We've taken over 200 transfers out of 3 of the major health systems in Southeastern Michigan, both in the ED and the ICU. We've tried to accept whenever we can. We have about over 200 COVID positive patients in the health system now, many of them in the ICU. We're still in kind of surge capacity in terms of our ICU capacity. Our ICUs are twice as full as they usually are, although we've been able to leverage a lot of our kind of non-traditional space and convert into ICUs, including the PACU, traditional floor units, and other places. We also were fortunate to have a little bit of lead time to stand up our RICU, which is our regional infectious containment units, a 32-bed negative pressure ICU that really only gets flexed up in pandemic cases like this. And so we're able to get that flexed up fairly quickly and utilize that pretty heavily, which has been a very positive resource for us. We've also worked with the state and the federal government to start to formulate plans to stand up a large field hospital on campus. But it's kind of ready to go, but has not been operationalized yet, as it hasn't been needed just yet, but we have been kind of planning for that stage as well. I think our initial experience, again, was kind of taking critically ill from other health systems in, with some de novo diagnoses here as well, but much less than I think Henry Ford and DMC have experienced. We did leverage kind of EC3 fairly heavily in our negative pressure rooms in the department, and made them kind of airborne or aerosol generating procedure rooms to do all of our intubations, our heated high flow, and other care. We are using heated high flow up to 60 liters a minute and up to 100%. We have used non-invasive kind of sparingly, mostly in patients, as Jackie said, that have other kind of comorbidities that required non-invasive outside of COVID. We have been leveraged fairly heavily in kind of designing protocols, both for emergency medicine and the institution, for airway management in these patients, cardiac arrest management, and some of the early proning protocols have come kind of from us. We are also leveraging a biomarker strategy, or working on that to try to risk stratify patients. And then again, I think really heavily looking at staff safety, I think like everybody else is being fairly crucial. And so we've been using in our AGP room, using baby monitors to limit the number of times staffs have to kind of come in and out in order to communicate, to save PPE and save exposures. We've done some innovation work here as well with a helmet and some other things that we're trying to use for heated high flow and aerosol and nebulizer treatments to try to limit some of the aerosolization that comes during respiratory therapy. And then we also are recently started sterilizing our N95s for reuse in order to save PPE that way as well. So I think I'll turn it over to David too, and see what he wants to add, and then we can kind of sum up at the end.
Yeah, so thank you. I'll echo some of the same comments that have been made about management and offer a bit of flavor that I've experienced so far. So I would say, just in terms of PPE, both for us and for patients, one thing I haven't heard commented on thus far is placing the patient in a mask. Goes a long way towards minimizing the droplet dispersion for multiple of these different interventions, so that we have a lower burden of droplets in the room for providers to be exposed to, even when they're in negative pressure or isolation of some sort. You know, the progression that I've seen for these patients is a pretty rapid, pretty dramatic course, rising from no oxygen requirement to a nasal cannula, and then within just the space of a few hours proceeding to a high flow nasal cannula, which for us is a 15 liter per minute cannula, and then to heated high flow nasal cannula up to 60 liters and 100%. Again, this we're doing in a negative pressure room to protect against droplet aerosolization. And then for me, you know, the question about what to do at that point in time, depending on your resources and depending on what the patient looks like, what their gases are trending like, you know, the decision at that point to either intubate as you're up titrating on the heated high flow versus trial some kind of a non-invasive. And when I say non-invasive here, I'm talking specifically about CPAP. I'm trying to avoid BiPAP in these patients out of concern for volume trauma and really not having any control over their tidal volumes. Using CPAP, however, to augment their oxygenation seems to be working in a certain group of these patients. And I've yet to be able to tell ahead of time who it's going to work in and who it doesn't work in. So I'm trying it to see if I can buy myself some extra time. And if I can't buy time with it, then at least I'm working towards pre-oxygenating the patient and also seeing the degree of effect that the positive pressure has on their right heart function. Because a lot of these patients are also experiencing pretty significant right heart afterload increases with the hypoxia. And so I want to make sure that they're going to be hemodynamically stable in the face of an intubation. So along those lines, I'm also, as they up titrate on their oxygen therapy, placing an A-line pretty early in these folks to try and both and get a sense of what their PaO2, FiO2 ratio is doing throughout their course, but also to get a sense of their hemodynamics, again, in preparation for intubation. So I would say, out of concern for droplet aerosolization, one of the things that we've been doing is in our inpatients, we've been converting them over to different vent types so that we can preserve one of our vent types, the Draeger vents that we use most commonly during normal circumstances. The benefit there is that the Draeger can not only act as a heated high flow circuit, it can also act as a non-invasive circuit providing CPAP and BiPAP, but then you can transition that same ventilator to a patient for intubation and mechanical ventilation should you need to. That way you have all of the tools kind of in one kit, much like a Swiss Army knife, and that gives you an opportunity to trial those different interventions without having to bring a lot of different equipment into the room. So I will leave it there, as I'm sure there are plenty of questions and we're starting to run a little short on time, and I want to make sure that we have a chance to open the forum.
Absolutely. No, I appreciate that, Dr. Hackinson. So in the background, my team has been monitoring the chat function, and certainly just as a reminder, for those that want to submit questions or comments, please use the chat function because you all are going to stay on mute just so we can manage the background noise. So Michelle Neipaver or Curious Smith, these are from the Med According Center. Any questions for the panelists?
Hey everybody, thanks very much. This has been super interesting, and thanks everybody for your willingness to share. We've been monitoring some of the details that have come up through our conversation here. Again, if you have questions as you listen to each site with all their details, put them in the chat so we can pull them into the conversation. I just was interesting, and I'd be curious to hear a little bit more from either Sinai Grace or Henry Ford Hospital about any progressive sort of decision-making in terms of respiratory support, such that, if you do this, then this, then this, then this. And I heard a little bit from each site, but I'm just curious. I heard from Michigan Medicine about trying to, adjudicate which kind of ventilators people would go on and using some of those things. So I'm just kind of interested if any of that was done at the other sites as well.
I can probably talk a little bit about that. So we actually had within two documents. One was a aerosol generating procedure document that Namita kind of spoke on, which is what cohorted our patients in certain areas. We defined each of the different oxygenation possibilities because what we kind of found as we were going along is our understanding from the critical care training of what our options were was a little different than some of our colleagues' understanding. When we said Salter versus Optiflow, we had to redefine those. And so we had a document where we basically had a progressive flow chart of Salter device up to 15 liters, then Optiflow, and we only did up to 30 liters based on some of the MERS data with the aerosolization possibilities. We studied up to 30 liters, so we didn't advance to 60 liters. That was our kind of ceiling. Once you hit 30 liters and 100%, then the option was intubate, unless they were DNI or comfort care, in which case we were, in some cases, putting non-rebreathers over top of the high flow nasal cannulas or the Salter cannulas when we needed to. But BiPAP was kind of a separate algorithm altogether. So we didn't use BiPAP in patients unless we thought they had a temporary co-condition like COPD or flash pulmonary edema or CHF that we thought we could fix within the amount of time that we could actually take them off BiPAP and just put them on oxygen.
Any other responses from DMC, Sinai Grace?
At Sinai Grace, we essentially did not use BiPAP. The initial recommendations from Wuhan was not to do it. And therefore, we actually took our BiPAPs and converted them over to ventilators, normal ventilators. We have about 30 of them, and they can, I think it's 30, they could be switched over. So initially, considering how many ventilators we had, we were actually using the BiPAPs as vents too, and didn't use CPAP or BiPAP within our department because of the concern of the aerosolization. Even though later on we were starting to consider it because we did have filters on them, and considering of undoing some of the transfers we did as we had more ventilators available that we got from the region.
Thanks. Ben or Dave, did you guys have any questions for our other guests?
I would just say, I'm
Sorry,
curious.
go ahead.
Oh, sorry, David. Just curious. I've talked to a lot of our inpatient intensivists on kind of their experiencing managing, the critically ill COVID patients, and you've probably seen the literature from Gattinoni about the L versus H phenotype, which is, the L is everything is low, so low elastance, high compliance, low VQ shunt, and versus the H phenotype, which is, typical ARDS patient, really low compliance, high VQ shunting, high elastance, and our experience, at least from hearing from a lot of the ICU directors here, is that most of the patients have fallen into the H phenotype, which they generally respond to kind of classic ARDS treatment. So, proning, low tidal volumes, paralyzation early, potentially pressure control, ventilation, and other things that would, normally be the high PEEP tables that we do for ARDS patients. I'm just curious if at the other hospitals, if you've seen the same kind of thing, or if whether you're really truly seeing this heterogeneous disease continuum of patients who are, who aren't falling into one bucket or another.
This is Namita. I just finished up rounding for 2 weeks in the ICU. And so my experience has been a little bit of both. So early on, there seems to be a response to the H phenotype recruitability. And then as the course goes on, there is a subgroup of patients who are falling into a little bit of the L phenotype, where it's becoming more of an oxygenation issue, and a little bit more of the oxygen is just not diffusing across the alveolus. So it's been interesting to sort of evolve the management of these ARDS patients, starting with just the ARDSNet protocols, but then recognizing as time goes on, it is really an oxygen diffusion issue. And so the utilization of proning and high PEEPs may be just more of increasing the available surface area. But most definitely, we're seeing a mixture of those. The patients don't have the similar type of low compliance that you would anticipate from our classical understanding of ARDS. They all have higher compliance, but oxygenation and diffusion of that oxygen really seems to be the primary driving aspect of the illness.
Thanks, everybody. We have, in the interest of time, I'm going to plow through a little bit because there's some questions coming up on chat. Brian O'Neill has a question, and it's related to whether you're using hydroxychloroquine or not. I can first address that maybe to Ben and Basson at Michigan Medicine. I'll let each site respond to that.
Hydroxychloroquine, and I can defer to David too, but we are not empirically treating any patients, at least at the ED phase, with hydroxychloroquine. There was a time initially when the data was coming out that if they were critically ill, they were potentially getting a dose. It's been fully kind of in the ball or the court of our infectious disease docs. So they're getting consulted early if patients are critically ill and deciding kind of who gets it. But my understanding from the inpatient ICU directors has been that there's really been no difference in kind of outcomes related to that specifically. And so I think they're getting away from using it, is my understanding, but I can't comment specifically. But in the ED, we're not empirically using it.
Dr. Messman, can you respond from your side?
Yeah, so I would say it has changed greatly. We went from not using it to using it on everybody with the steroids, and then we're kind of going full circle, and I would say that now we're largely not using it. and sort of leaving it up to the decision of the admitting team. We are getting, I know Dr. was asking about population, I already sort of alluded to this, but we are consistently becoming more aggressive with using Lovenox, but not hydroxychloroquine.
From Henry Ford, the protocol actually still calls for hydroxychloroquine, but we will be re-evaluating this once our PETL NIH clinical trial that we are combining with UFM, once that gets up and running, we'll reevaluate it. So far, we are not able to piece out hydroxychloroquine showing anything spectacular. We have not had any major side effects related to that, but so ideally this drug needs to be studied in a clinical trial setting with the placebo arm, because since the benefit seems to be marginal at the best at this point of time. So that process will happen very soon, and then we'll change our management guidelines at that point.
So I'm going to pivot here just a little bit in the interest of time again. There are some questions regarding the sedation practices for these patients. And they feel that they're hypermetabolic state, that they are requiring high levels of sedation, where there's a question as to what sedation practices at the different hospitals have been put in place. How about we start with Sinai Grace?
So I can speak to both Sinai Grace and Detroit Receive. Honestly, what's available is using, because it's true that the patients are eating through so much sedation, fentanyl, everything. So a lot of times it just depends on what we have. We've had incredible shortages of fentanyl, and then we'll get a shipment in and we'll be able to use it for a couple of days. So we've had to get creative with what we're using. I've had to go use ketamine if propofol wasn't an option because of borderline blood pressures, but we've been sort of limited by our resources about available.
I would say here at Michigan Medicine, we've had some shortages, decline in the stocks of medications, in particular things like Versed, but we've been able to keep folks pretty well sedated with, for the most part, propofol and fentanyl.
Thanks. Henry Ford, any quickies?
This is Jackie Flom again. One of our other EM critical care staff, Jana Gardner-Gray, is actually instrumental in developing a deep sedation protocol in conjunction with anesthesia that had the patients on heavier sedation and then took into account some of the shortages. Up in the ICUs, they had some options with phenobarb and pentobarb. We did not adapt those in the ER because of the training required of nursing for some of those. But we have been fortunate in the emergency department that we didn't have the shortages they were experiencing up in the ICUs.
Thank you. I have one other question. I think people were talking a little bit about PEEP, high PEEP versus, how you define high PEEP on the chat here. Ben or Namita, you want to address that?
Yeah, I can speak to that. There's been, for me, it's all over the place, and I think it depends very much on where you intersect with the patient in terms of the course of their disease. The patient early on that has an oxygen requirement, if they have good compliance and you titrate their PEEP to match their compliance, then I found that they're doing pretty well on 10 or 12 of PEEP. Then these patients turn into the typical ARDS monster and they end up on much higher PEEP. And so I don't know where the right answer is, or if there is a right answer across the entire disease spectrum, or if it's something that you have to dynamically address on a day-to-day basis for each of the patients, depending on where they are in their disease. This is a really confusing disease process that I wish we had more insight to, and I think that as time goes on, we're going to find out there's a lot more going on here than we understand.
Dave, can I ask you one other question? At Michigan Medicine, what are you doing in terms of fluids? Are you running people dry, euvolemic, or somewhere?
Yeah, we are tending to run them pretty dry. I think for the most part, the hemodynamics of these patients, apart from intubation, hasn't been an issue. Most of these folks don't come in shock. Certainly as the disease progresses, that can change, but early on, they're what I've been seeing as termed as the happy hypoxic. So they're tachypnic and they're markedly hypoxic, but otherwise they look very comfortable. They're talking to you, they're awake, they're mentating even when their oxygen saturations are in the 80s or even 70s, and that's confirmed on ABG. To speak to one of the other questions about intubating these patients, certainly that puts the right heart, the active intubation in the face of marked hypoxia, puts the right heart pretty significant detriment. And so that's why I've been putting art lines in these patients early, not shying away from hemodynamic support, even in a patient that looks pretty reasonable. And again, on the Draeger machines where I have the ability to have a viral filter in line with them, putting them on CPAP ahead of time, sort of testing the waters to see how their RV is going to handle that increase in intrathoracic pressure. And so far, that has allowed me to intubate patients, even with marked hypoxia, without any real significant hemodynamic consequences.
Thanks, Dave. I'm going to interrupt because we just have a couple minutes here, and we're certainly willing to stay on for a little bit longer if people can stay. I would like to just spend the last couple minutes with some parting advice. And remember, your advice and your experience is being watched by providers around the state and community hospitals that do not have the resources that most of us on this call do have. So just if you can give me a 1 or 2 sentence, your big advice, highlighted topics from each site, starting with Henry Ford, we'd appreciate it.
I think, this is Namita, I think our biggest advice maybe be open to adaptation as we learn more about the illness. As COVID-19, certainly from a critical illness perspective, seems to be primarily attacking the lungs. It is an inflammatory cascade response. And so as we move forward, I think we'll see different presentations. We're already starting to see a second wave where it seems like a myocarditis, pericarditis may start to be playing into it. So knowing the physiological principles of why we have ARDS protocols and septic shock protocols, and then willingness to adapt as you see different physiologies.
Thank you. Dr. Messman?
I would say something important that we've learned, because we did this very early, was making sure I was wearing full PPE for their shift. We haven't had any physicians get sick. Did have a couple of residents positive. They're a little more lax with their PPE, but none of the attending physicians have gotten sick. And also just making sure that there's a clear line of communication from the people that are making decisions in terms of guidelines for management and treatment, so that people are practicing medicine as uniformly as we can and not, just kind of all over the place. Especially as new information comes out, there should be a central person that's responsible for disseminating that.
I think that's really been very helpful. It was a central theme, I think, and great advice to somebody as a point person, just to monitor all the things that you're having to adapt to. That's a really important point. Ben or Dave, do you have any final parting thoughts?
I would probably just echo, what Namita said, which is, 10 days ago or 2 weeks ago, we wrote kind of the critical care consensus recommendations for the health system. And, some of those things are already outdated because it's moving so quickly. So just staying flexible. I think this forum is fantastic. I would encourage people to continue to use, this forum to gain, experience and best practices, as this disease is only a couple months old, from other health systems in the state, as we all experience, the rapidly evolving pathophysiology of it, to kind of see what other people are seeing, and use this forum to communicate. The other thing I've been really pleasantly surprised by, if there is a silver lining to all of this, is really, what is possible when everybody kind of unites around a singular goal, and the way that we are able to rapidly shift our operations, our patient care abilities, to collaborate across Southeastern Michigan to really, start spinning into the innovation space and really come up with just-in-time solutions for some of the challenges it's facing, has really been quite remarkable. And so I think there is some silver lining that has come out of this, and I would just encourage people to kind of stay the course and continue to share as much information as they can so we can all benefit.
Thank you all. Keith, I'm going to turn it back over to you for closure. Thanks very much for everybody's time.
Yeah, it's been wonderful. I certainly appreciate all the panelists. I mean, we had to, advocate, get them in, like I said in the beginning, on a week's notice, and everybody stepped up. We really appreciate that, and certainly appreciate Ben's echoing what we think is also the value of a learning collaborative like this, where we can disseminate information rapidly, across the state. On that point, we are going to be posting this to the Medic website. We have already some materials there as a landing spot, so certainly look there. And we may be planning additional town hall forums like this, depending on need. Please reach out if we can help, and stay safe out there. We're going to sign out. Thank you.
Thanks, everyone. Have a great day.
Thank you.